Azlan Adnan, M.A., presents Retinitis Pigmentosa, the inherited retinal disorders that progressively narrow the world of sight, an overview of causes, symptoms, diagnosis, treatment, and emerging therapies. Saturday, 22 August 2026. Retinitis pigmentosa, RP, is not a single disease but a group of rare inherited retinal dystrophies in which the light-sensitive photoreceptor cells of the retina progressively degenerate. The disease usually affects rod photoreceptors first, followed by the cone photoreceptors, while the retinal pigment epithelium, which supports and maintains the photoreceptors, also undergoes progressive changes. The consequences are typically gradual rather than sudden. Night vision becomes increasingly poor, adaptation to darkness takes longer, and peripheral vision progressively contracts. Over time, the visual field may become so restricted that the person experiences what is commonly described as tunnel vision. In more advanced disease, the cones are increasingly affected and central vision, visual acuity, and color perception may deteriorate as well. Despite its name, retinitis pigmentosa is not primarily an inflammatory disease. The term retinitis is historical and somewhat misleading. The pigmentosa refers to the characteristic deposits of pigment that develop in the retina as photoreceptors and associated retinal tissues degenerate. RP is the most common group of inherited retinal dystrophies and is an important cause of progressive visual disability. Although it can eventually lead to profound blindness, its course is highly variable. Some people retain useful central vision for much of their lives, while others experience substantial visual impairment at a comparatively young age. Prevalence and epidemiology. Estimates of the prevalence of RP vary according to the population studied and the diagnostic criteria used. A commonly cited range is approximately 1 person in 3,000 to 5,000 worldwide, although studies have produced estimates ranging from roughly 1 in 3,000 to 1 in 7,000. Taken together, these figures suggest that more than 1.5 million people worldwide may be affected. In the United States, approximately 100,000 people are estimated to have RP. There is no strong overall ethnic predilection, although particular populations can have substantially higher frequencies because of founder effects, genetic isolation, or higher rates of consanguinity. RP can occur in both males and females, but the inheritance pattern influences who is affected and how severely the disease progresses. Because several different genetic mechanisms can produce a broadly similar retinal phenotype, RP is better understood as a large family of related disorders rather than as a single condition. The genetic foundations of retinitis pigmentosa. At its core, RP is a genetic disorder of the retina. Pathogenic variants in genes involved in photoreceptor structure, phototransduction, cellular metabolism, ciliary function, intracellular transport, and the maintenance of the retinal pigment epithelium can disrupt the highly specialized machinery required for vision. More than 80 to 100 genes have been implicated in non-syndromic RP, with thousands of individual pathogenic variants identified. The number becomes considerably greater when syndromic forms of inherited retinal degeneration are included. RP can be inherited in several ways. Autosomal dominant disease accounts for approximately 15 to 25% of cases, while autosomal recessive forms account for perhaps 5 to 20%. X-linked disease represents roughly 5 to 15%. A substantial proportion of patients have no immediately apparent family history and are classified as simplex or sporadic cases. These may result from recessive inheritance in which both parents are unaffected carriers, a newly arising pathogenic variant, or an incompletely understood inheritance pattern. Much rarer mechanisms include digenic and mitochondrial inheritance. The particular gene involved can have a major influence on the clinical course. R-ROSI, which encodes the photoreceptor protein rhodopsin, is an important cause of autosomal dominant RP. RPGR is a major cause of X-linked RP. USH2A is another important gene and can cause both non-syndromic RP and Usher syndrome. Inheritance patterns can also provide clues about prognosis, although they cannot reliably predict an individual's course. X-linked RP is often relatively severe and may progress more rapidly, whereas many autosomal dominant forms are comparatively milder. Considerable variation nevertheless exists within every inheritance category, non-syndromic and syndromic RP. Approximately 70 to 80% of cases are generally regarded as non-syndromic, meaning that the retinal degeneration occurs without a major associated systemic disorder. The remainder occur as part of broader genetic syndromes. One of the most important is Usher syndrome, in which RP is associated with sensory neural hearing loss. Usher syndrome is the most common syndromic form of inherited retinal degeneration. Another is Bardet-Biedl syndrome, a multisystem genetic disorder that can include retinal dystrophy alongside other systemic manifestations. Recognizing a syndromic form is important because the retinal findings may be only one component of a much broader genetic condition. This is one reason modern genetic diagnosis has become increasingly important in the management of inherited retinal disease. The characteristic progression of vision loss. The classical presentation begins with difficulty seeing in dim illumination. This condition, known as nyctalopia or night blindness, occurs because rod photoreceptors are normally responsible for vision under low light conditions and are usually the first photoreceptors to deteriorate. A person may notice difficulty walking outdoors after sunset, navigating dimly lit rooms, or adjusting when moving from a brightly illuminated environment into darkness. Dark adaptation becomes progressively slower and less effective. As degeneration advances, peripheral vision begins to disappear. The remaining field may become separated from the lost peripheral areas by regions of impaired sensitivity known as scotomas. These can progressively enlarge and merge, eventually producing the characteristic constricted or tunnel visual field. The progression is often gradual enough that people may initially compensate without realizing how much peripheral vision they have lost. Difficulties may become particularly apparent when navigating unfamiliar environments, avoiding obstacles, crossing roads, or moving through crowded spaces. Eventually, cone photoreceptors become increasingly affected. This can result in declining central visual acuity, impaired color discrimination, and increased sensitivity to bright light, known as photophobia. The distinction between central and peripheral impairment is important because central vision can remain relatively well preserved for many years in some patients, even after substantial peripheral vision has disappeared. The timing and severity of these stages vary enormously. Many people experience significant visual field loss by middle age, while central vision may remain functional considerably longer. In other genetic subtypes, however, central vision can deteriorate much earlier. It is therefore impossible to assign a single timetable to RP. Associated retinal complications. RP can produce complications in addition to the primary photoreceptor degeneration. Posterior subcapsular cataracts are relatively common and can further reduce visual acuity or increase glare. Cystoid macular edema can also occur. In this condition, fluid accumulates within the macula, the specialized central region of the retina responsible for detailed vision. Although the underlying retinal degeneration cannot simply be attributed to the edema, treating the macular complication can sometimes improve or stabilize remaining central vision. These complications are important because not every decline in vision in a person with RP necessarily represents irreversible progression of the underlying dystrophy. Some additional causes of visual deterioration can be identified and treated. Diagnosing retinitis pigmentosa. Diagnosis begins with a detailed history and ophthalmic examination. A dilated examination of the retina may reveal the characteristic combination of findings traditionally associated with RP: bone spicule pigmentation, attenuation of the retinal blood vessels, and a pale or waxy appearance of the optic disc. The pigmentation is produced by abnormal distribution and migration of retinal pigment epithelial cells as the retina degenerates. It often becomes particularly evident in the peripheral and equatorial retina, although its distribution can vary substantially between genetic subtypes. Electroretinography, ERG, has historically been one of the most important objective tests for confirming retinal dysfunction. It measures the electrical responses generated by the retina in response to light. In classical RP, rod responses become markedly reduced or may eventually become undetectable, followed by deterioration of cone responses. Modern diagnosis uses a broader range of technologies. Visual field testing objectively measures the extent and distribution of functional vision. Optical coherence tomography, OCT, provides high-resolution cross-sectional images of the retina and can reveal structural changes in the photoreceptor layers and macula. Fundus autofluorescence can map characteristic patterns of retinal pigment epithelial dysfunction and may help assess the remaining viable retina. Genetic testing has become increasingly important. Identifying the pathogenic variant can confirm the molecular diagnosis, clarify inheritance, assist with genetic counseling, and help establish eligibility for certain mutation-specific clinical trials or treatments. Current management. For most forms of RP, there is currently no treatment capable of restoring photoreceptors that have already been lost. Management therefore focuses on preserving remaining function, treating complications, improving functional independence, and helping patients adapt to progressive visual impairment. Nutritional supplementation has been investigated extensively, but the evidence is mixed and treatment should be individualized. Vitamin A palmitate was studied in earlier clinical trials, but high-dose vitamin A is not appropriate for everyone and can cause toxicity. It should therefore never be taken at high doses without medical supervision. Lutein and zeaxanthin and omega-3 fatty acids have also been investigated, although supplementation should not be regarded as a proven means of stopping RP progression. Protection from excessive ultraviolet exposure, avoidance of smoking, and maintenance of general health are sensible measures, although they cannot prevent the genetic disorder itself. Regular ophthalmic monitoring is important both for tracking retinal degeneration and for detecting treatable complications. Cystoid macular edema may respond to carbonic anhydrase inhibitors, administered either topically or orally. Cataracts can be treated surgically when they become sufficiently significant to impair vision. For many people, however, rehabilitation is as important as medical treatment. Low vision aids, magnification, appropriate lighting, orientation and mobility training, assistive technology, and occupational rehabilitation can help people make effective use of their remaining vision and maintain independence. The first gene therapy for an inherited retinal disease, a major milestone in inherited retinal medicine, came with the development of voretigene neparvovic, marketed as Luxturna. This treatment is designed specifically for people with confirmed biallelic pathogenic variants in RPE65, a gene required for the visual cycle. RPE65-associated retinal degeneration is uncommon, but it demonstrated that a genetic defect causing inherited blindness could be treated directly at the molecular level. Voretigene neparvovic delivers a functional copy of the RPE65 gene through a one-time subretinal administration. The treatment is therefore highly specific. It is not a general treatment for RP and cannot be used for people whose disease is caused by other genes. Nevertheless, its development established an important principle that has transformed research into inherited retinal disease. The genetic cause itself can become a therapeutic target. The emerging era of mutation-independent treatment. The most exciting developments in RP research increasingly involve approaches that do not depend on identifying one particular mutation. This is especially important because RP has such an extraordinary degree of genetic heterogeneity. A treatment capable of bypassing the original genetic defect could potentially benefit patients with many different forms of the disease. One such approach is optogenetic therapy. Instead of attempting to repair the original mutation, optogenetics introduces light-sensitive proteins into surviving retinal cells that would not normally function as photoreceptors. The objective is effectively to create a new light detection pathway from cells that remain after the original photoreceptors have degenerated. Sonpiritigene istoparvovec, also known as MCO-010, is one of the most advanced examples of this strategy. It is being investigated as a gene-agnostic treatment for advanced RP, using an intravitreal injection to deliver a genetic construct designed to make surviving retinal cells responsive to light. Clinical development has reported encouraging improvements in visual function, including sustained gains in best-corrected visual acuity in patients with advanced RP. Regulatory development has also progressed, including the submission of a rolling biologics license application in the United States and receipt of Regenerative Medicine Advanced Therapy designation from the U.S. Food and Drug Administration. Other research programs are pursuing gene replacement and gene editing strategies for specific forms of RP. X-linked RP caused by pathogenic variants in RPGR is one particularly active area of investigation, with clinical studies producing encouraging results. Scientists are also investigating neuroprotective treatments designed to keep damaged photoreceptors alive for longer. Photoswitch molecules capable of restoring light sensitivity to surviving retinal cells, stem cell approaches, and retinal prostheses. Genome-wide studies are additionally being used to identify genes and molecular pathways that might protect retinal cells from degeneration regardless of the original mutation. The importance of genetic diagnosis. The growing number of potential treatments makes genetic diagnosis more than an academic exercise. Knowing the precise molecular cause of RP can determine whether a patient is eligible for a mutation-specific therapy or clinical trial and can provide information about inheritance and potential risks to relatives. Genetic counseling is consequently an important component of modern RP care. A confirmed diagnosis can allow families to understand how the condition is inherited and, where appropriate, discuss reproductive options and genetic testing for relatives. Genetic information can also become increasingly valuable as new treatments emerge. A patient whose condition cannot currently be treated may nevertheless have a genetic diagnosis that makes them eligible for a future clinical trial. Living with a progressive retinal dystrophy. The experience of RP extends beyond measurements of visual acuity. A person can retain relatively good central acuity while having severe impairment of the visual field, making conventional measures of eyesight an incomplete representation of functional vision. Someone with substantial peripheral field loss may read relatively small print yet have considerable difficulty walking safely through an unfamiliar environment. Conversely, another person may have reduced acuity but retain a sufficiently broad field to navigate independently. Effective care must therefore consider the entire visual system and the person's functional requirements rather than focusing solely on a single acuity measurement. Early rehabilitation can be particularly valuable. Learning orientation and mobility techniques, making appropriate use of magnification and electronic accessibility tools, improving environmental lighting, and reducing hazards can help people adapt before visual loss becomes severe. Outlook. The prognosis of retinitis pigmentosa varies enormously because RP represents a large collection of genetically distinct retinal disorders rather than one uniform disease. The particular gene involved, the pathogenic variant, inheritance pattern, and individual biological factors can all influence the rate and pattern of degeneration. For decades, treatment was largely limited to managing complications and adapting to progressive visual loss. That situation is changing. The success of RPE65 gene therapy has demonstrated that inherited retinal degeneration can be directly targeted, while optogenetics, gene therapy, neuroprotection, molecular photoswitches, cell-based approaches, and retinal prostheses are expanding the range of possible strategies. The most important developments may ultimately come from combining these approaches. Some therapies seek to correct the original genetic defect. Others attempt to preserve surviving photoreceptors, and still others seek to restore light sensitivity after photoreceptors have been lost. Retinitis pigmentosa remains a serious cause of progressive visual disability, but it is no longer a field defined solely by inevitable deterioration and supportive care. Advances in molecular genetics, retinal imaging, gene therapy, and regenerative medicine are progressively changing the therapeutic landscape. Early diagnosis, appropriate genetic testing, regular retinal monitoring, and timely access to visual rehabilitation therefore have greater importance than ever. For anyone diagnosed with RP or for a family in which the condition occurs, assessment by a retinal specialist and access to genetic counseling can provide a clearer understanding of the specific disease involved, its likely course, and the treatments or clinical trials for which the individual may be eligible. The science cannot yet reverse most forms of RP, but the transition from understanding inherited retinal degeneration to actively treating its molecular and cellular causes represents one of the most significant developments in modern ophthalmology. The author has placed this work in the public domain. It may be freely imported, exported, shared, distributed, edited, modified, or reformatted without explicit consent from the author. As a visually impaired person, the author asserts his rights under the Marrakesh Treaty to facilitate access to published works for persons who are blind, visually impaired, or otherwise print disabled. 2013, wipo.int.
Share your thoughts in the comments below. Don't forget to like this video and subscribe to our channel to show your support.